The most frequent etiologies for right ventricular thrombus include cardiomyopathy and its low output state, post-infarction, and the unique subgroup of cardiac contusion. An example of right ventricular thrombus is shown in this 5-year-old male with severe pulmonary hypertension. On short axis peristernal scan, a highly refractile mass in the right ventricular cavity is very suggestive of thrombus. In patients with pulmonary hypertension, this is a common observation. However, post-infarction and cardiac contusion also have similar observations. Multiple projections must be obtained to exclude moderator band or large muscle bundles. This is a 2-chamber scan, apex down, in the same patient. Note that there is a mass located in the apex of right ventricle. The right ventricle and right atrium are dilated. The ovoid mass, suggestive of thrombus, is adherent to the moderator band in right ventricle. The left-sided chambers appear to be compressed laterally. The ovoid appearance and adherence to the underlying myocardium is very suggestive of thrombus associated with severe pulmonary hypertension. The most common etiologies of extracardiac thrombus include perioperative hematoma and acute bleed into the pericardial sac. The example to be shown is a 59-year-old male with a postoperative hematoma presenting with cardiac tamponade. In this peristernal short-axis scan at the level of the prosthesis, marked P, a hematoma is visualized compressing inward to the right atrial cavity. This is a typical location of a perioperative hematoma. Tamponade is caused by inflow obstruction to the right atrium. This should be suspected in patients with postoperative bleed and sudden hemodynamic compromise. This is the apex up 4-chamber scan. Note that the hematoma is localized posterior to the right atrial cavity. This cystic mass compresses the right atrial cavity and compromises the right ventricular inflow. This is a very typical location for the perioperative hematoma. Note that there's no pericardial effusion, ventricular function is preserved. However, this large hematoma compresses the right atrium, compromises inflow, and invariably needs surgical decompression. Recognition of this thrombus formation is most important in the perioperative period. The next topic is vegetative endocarditis, its echocardiographic recognition, diagnosis of complications, and relative value of transesophageal echocardiography. The first example is an 88-year-old female with flail aortic cusp secondary to Streptococcus viridans aortic valve endocarditis. Note that the transducer is adjacent to the left atrial cavity. The aortic valve cusps are visualized centrally. Note that one of the aortic cusps prolapses into the left ventricular outflow tract. There's also small pedunculated masses consistent with vegetation attached to the aortic cusp. On magnified view, the flail cusp is easily visualized and highlights the value of transesophageal echocardiography. Color flow Doppler shows the expectedly severe aortic valve regurgitation. The turbulent alias jet regurgitates into the left ventricular outflow tract. This is a 75-year-old female with aortic root abscess secondary to infective endocarditis. Transesophageal echocardiography is considered the diagnostic echocardiographic procedure of choice. Transducer is adjacent to left atrium. Posterior to an aortic prosthesis is a cystic structure compatible with abscess. The refractal struts of the prosthesis are visualized. The abscess is posterior. Note that there are small pedunculated vegetations attached to the bioprosthetic cusps. The abscess is located posteriorly. The vegetations prolapse into the left ventricular outflow tract. The abscess appears expansile, suggesting communication with the left ventricular outflow tract. On expanded or magnified views, notice the mass is expansile. You can see portions of the bioprosthetic cusps and the adherent vegetations. With color flow Doppler, an alias signal fills the abscess cavity, confirming communication between the left ventricular outflow tract and the abscess. There is mild mitral valve regurgitation. The next two examples are of mitral valve endocarditis, the first in a 77-year-old male with Streptococcus viridans endocarditis. On apical four-chamber view, the mitral valve appears thickened and distorted. In real time, a pedunculated vegetation and prolapse of the mitral apparatus is clearly visualized. Precordial echocardiography has approximately a 50% sensitivity for the detection of vegetative endocarditis. The second example is a 59-year-old male with Streptococcus viridans bacteremia. On a precordial long-axis scan of left ventricle, the mitral valve appears thickened and there is mitral annular calcification. A clear vegetation is not evident in this examination. In this subgroup of patients, transesophageal echocardiography has been shown to be superior and increase the sensitivity from 50% to 80 to 90%. This is the transesophageal examination in the same patient. On the posterior leaflet of mitral valve is a highly refractile mass consistent with vegetation. In real time, this pedunculated mass is most evident. This mass was not visible on precordial echo and highlights the superiority of transesophageal echocardiography for the diagnosis of vegetative endocarditis and its complications. Notice the pedunculated nature of this large vegetation. It prolapses into the left atrial cavity and is adherent to the posterior leaflet of mitral valve. With color flow Doppler, severe mitral valve regurgitation is evident as a disturbed jet filling the left atrial cavity. Transesophageal echocardiography has also become the procedure of choice for the assessment of suspected endocarditis of prosthetic valves. This is a 68-year-old female with a mitral bioprosthesis. Note, in the left atrial cavity there is a mass extending from the posterior surface of the bioprosthesis. In real time, a pedunculated vegetation is clearly visible. Note the swirling blood in left atrial cavity, consistent with low output state. Posterior structures are not easily visible from the precordial examination because of the acoustic shadowing. However, transesophageal echocardiography allows adequate visualization of these posterior located vegetations and complications. Right-sided endocarditis is more typical of the intravenous drug-abusing population. However, this is a 3-year-old child with staphylococcal endocarditis. A large vegetation is visualized on the anterior leaflet of tricuspid valve. This vegetation prolapses between right ventricle and right atrium. In the right atrium, a mass of echoes represents a catheter in this immunologically compromised patient, which had seeded its infection to the tricuspid valve. This child ultimately survived this severe complication. The next discussion are common artifacts and masqueraders of cardiac masses. First example is a true artifact, that is a reverberation within the left ventricular cavity of an 18-year-old female with a dilated cardiomyopathy. On a peristernal long-axis scan, there is an ill-defined mass of echoes in the body of left ventricle. This mass of echoes does not appear to be adherent to the underlying endocardium and at times crosses anatomic planes. Various techniques are utilized to discriminate artifact from true intercardiac mass. Various depth settings, frequencies, and transducer positions should be utilized. Notice that the mass does not conform to any of the morphologic features of masses heretofore mentioned on this tape. On short-axis scan, this ill-defined mid-cavitary mass persists, although the gain settings and depth settings have not been changed. This undulating echo should represent an artifact. Note that there are no significant underlying wall motion abnormalities. When the scan field is widened, this mass of echoes disappears. And with the more narrow field of angle, the mass reappears. With the M-mode cursor, the mass also disappears. This is diagnostic of an artifact. Notice that the artifact reappears with the M-mode turned off. A common masquerader of cardiac mass is a diaphragmatic hernia. This is an elderly patient with a large diaphragmatic hernia prolapsing beneath the left atrial cavity. This is with the apex up. Notice that in the left atrium, an ovoid mass appears. Also, periodically, you'll notice air within this mass as the patient swallows some carbonated beverage. This mass occasionally is confused as either a solid tumor or an atrial myxoma. Swallowing carbonated beverage will frequently elucidate the etiology. Also, a plain upright chest X-ray will assist in diagnosing diaphragmatic hernia. Another masquerader of cardiac mass is an excessively large calcified mitral annulus, usually seen in the elderly. This is an apex down four-chamber view, and in the mitral annulus there's a large calcified mass of echoes. This is simply an excessive calcification of the mitral annulus and should not be confused with pathology. Another masquerader of a thoracic tumor is a large thoracic aortic aneurysm posterior to the heart. This is a 67-year-old patient. This is an apex up four-chamber view, and posterior to the left atrium is a cystic mass consistent with thoracic aortic aneurysm. The anatomic position of this mass should suggest thoracic aorta. In the peristernal long-axis scan, the large thoracic aortic aneurysm is located posterior to the left atrium. One mechanism of identifying this as aorta is to attempt to image the aorta in long axis. Transesophageal echocardiography, however, is a more diagnostic procedure and would delineate aortic aneurysm from tumor. The last masquerader is a large redundant eustachian valve, typically seen in younger patients, confused with atrial myxoma, thrombus, or tumor. Its attachment is at the orifice of the infravena cava. Note, in real time, the eustachian valve has an undulating motion within the right atrial cavity. It has a picture similar to that of a migratory thrombus. Its location at the orifice of the infravena cava is diagnostic. In this long-axis scan into the right ventricular inflow, notice that the eustachian valve is attached at the orifice of the infravena cava, has an undulating motion in the right atrial cavity, and should be diagnostic of a large redundant eustachian valve. Two-dimensional and transesophageal echocardiography have markedly improved the ability to diagnose and characterize cardiac tumors, thrombus, and vegetations. By knowing pitfalls, characteristic presentations, echocardiographic appearance, and pathophysiology, a correct diagnosis can be made by non-invasive echocardiography.